I would like to welcome you back to Revolutionizing Healthcare, to our first session of 2025. And this is going to be a particularly interesting one, I believe. Tim, if you could skip to the next slide. Today, we're going to have a discussion on the future of artificial intelligence in healthcare. And we're really delighted to have, as Mihaela said, a star for this first session of the year with Dean Lloyd Minor from Stanford University. And Tim will introduce the panel in just a second. The overall structure of our session will be an introduction that's happening right now. Then we're going to dive into a conversation between Dean Minor and Professor van der Schaar. And then you will also have the ability to ask any questions you would like in the chat, and we will ask questions and get answers from our panel throughout the session. So please feel free to drop any questions you may have at any time, and we will ask them.
Okay, good afternoon or good morning, everyone. I'm thrilled to introduce our panelists for today. First of all, we have Professor Minor with us. He's the Dean of Stanford University School of Medicine and also serves as the Vice President for Medical Affairs at Stanford. His expertise spans head and neck surgery, neurobiology, bioengineering, and making him an invaluable panelist for our session today to talk about this topic. Next up is Professor Mihaela van der Schaar. She holds the John Humphrey Plummer Professorship in Machine Learning and AI and Medicine at the University of Cambridge, and she also leads this center, the Cambridge Center for AI and Medicine, also the center that is hosting these sessions. Her work is at the cutting edge of AI, and it's a pleasure to have these two panelists to engage in a conversation about the future of medicine. And with that, I'm pleased to hand over to you, Mihaela.
Very much, Tims, and welcome everyone. A very happy new year. We are delighted to have you here in these sessions. And what a pleasure it is for me and what an honor to have the opportunity to talk to Lloyd, with whom I've had the fantastic opportunity to talk about the future of AI in medicine quite a few years back. It's around 5 years ago, I think, Lloyd, that we last exchanged thoughts about this area. And we had a fantastic discussion. I was really so enthusiastic about the discussion I've had at the time. And I do still recall some of the key points you made at the time, and I may bring them back in our conversation today. So thank you very much for making time out of your super busy schedule to talk to us and inspire us. So I'm going to start by thinking about Stanford's pioneering role in healthcare innovation and what AI can bring to that. So, of course, for many years, Stanford Medical School has been a key innovator in the medical domain. And I wanted to really ask you, in your view, how has AI beyond radiology transformed healthcare at Stanford Medical School, and what unique factors enable these successes?
Well, thank you, Mihaela. It's wonderful to be with you and our other colleagues this morning or this afternoon, or whenever you're viewing this this event. And I'm honored to be able to share a few thoughts with you and also to get your feedback on what we're doing and the opportunities that I believe we all have in applying AI in health, biomedicine, and the delivery of healthcare. I think there are three areas where I think AI is having impact today in biomedicine, healthcare delivery, and will continue to have in the future. The first is in improving the efficiency and effectiveness of healthcare and of therapeutics and of everything we do in biomedicine. The second is improving access to care and democratizing access to care. That is bringing knowledge and skills and abilities to communities that traditionally have not had access to those basis of knowledge, skills, and ability. And then the third area is in improving health equity, and that's closely related to the second. And perhaps we can cover some aspect of all three of those in our conversation today. Insofar as what we're emphasizing at Stanford, a lot of, I think we're pioneering a lot of these advances, but certainly many other institutions are pursuing similar courses or various aspects of what we're doing here. a lot of the current application of AI in health and healthcare has to do with the back office functions of providing healthcare. You know, in the United States, approximately 20% of healthcare expenditures are related to administering the healthcare delivery system. Those expenditures have nothing to do with the actual delivery of care, with the interaction with patients, with healthcare providers. They have to do with administering a very complex system. We should be able to reduce those costs, right? And in so doing, devote more resources to the actual delivery of care. For example, a lot of the back office functions associated with billing, associated with documentation compliance, a lot of those functions can and are being revolutionized by the applications of generative AI and other forms of AI. So that's one immediate area of emphasis. Also, we're using AI in a, we're applying AI and beginning to implement it in ways that improve our ability to deliver high quality care. For example, using ambient AI to transcribe a clinic note from an encounter between a clinician and a patient. There's nothing more frustrating for both the clinician and the patient than for when a person goes in to see a physician or other healthcare provider, the first thing that provider does is to start typing into a terminal to document the encounter. They're not looking at the patient in the eye. How can you really focus on what the patient is saying and really have a deep, meaningful conversation with the patient if you're typing a note into a computer? So we have about 50 clinicians today who are deploying ambient AI. Of course, there are still kinks to be worked out. And in almost every case, the note that's prepared by ambient AI has to undergo editing by the physician and oftentimes by the patient as well. But we all know that that gets better with training, right? And we've chosen the clinicians who are using this initially are ones who are very well versed with using technology, who realize both the opportunities of the technology, but also the limitations. And we know that as they use it and it extends more broadly to other clinicians, that the AI will become more accurate and more meaningful. In talking to the physicians and the patients that are participating in these experiences, almost universally, almost entirely, it's receiving a positive feedback. Patients give it a positive feedback, that is the use of ambient AI, because now they're able to really communicate with a physician. Physicians give it a positive rating because they're able to really communicate with the patients and because it's offloading, if not completely offloading, and it isn't completely offloading, it's taking a lot of the documentation burden off of their shoulders. And we can see in real time how these transcription services, ambient AI services, are becoming more and more accurate as they become better and better trained. So that's an example of a deployment of AI technology in the delivery of care. Of course, we're using AI in radiology, as are many other places, and we're starting to deploy AI in the interpretation of pathology slides and images as well. So those are just a few examples.
Fantastic. Thank you so much, Lloyd. Are there maybe a follow-up question, and I'll ask both the positive version of it and the negative version of it to try to understand really the broader impacts of AI in healthcare in Stanford. So are there any particular domains, specialties, where you think AI integration would most benefit these areas, these clinical areas? Of course, when we talk about radiology and pathology, we talk indirectly about oncology, but are there other areas where you think AI can play a role, and what are those specialties? And then maybe a little bit of a different question, kind of conversely, has AI in healthcare failed to deliver on its promises at Stanford so far? And if this happened with a particular application of AI, are there any lessons we can draw from that, from those type of setbacks?
I think, the areas of most direct and short to intermediate term impact of the application of AI in healthcare and biomedicine are those areas most directly related to deriving inferences and meaning from large quantities of data. You mentioned, and we've talked about radiology, pathology. Other examples would be, for example, a patient has a very, very complex medical record. They have multiple medical comorbidities. They're receiving a lot of care from a lot of different physicians. Right now, that is stored in electronic filing cabinets, the electronic health record. Being able to digest that information in real time, synthesize it, and making sure that a physician who's seeing a patient, for example, for one particular problem, has a broad awareness of the patient's overall health condition, or a physician that's seeing a patient at 3 o'clock in the morning in the emergency department who's never seen the patient before can have, on an immediate basis, a synopsis that helps them deliver the best care to the patient at that moment in time. So processing large quantities of data, doing it in ways that no one human brain or small group of human brains can do is the area, of course, where AI is going to have the most immediate impact. I think more broadly, then, it's well, how do we all become more comfortable with both the opportunities and the limitations, particularly of large language models and generative AI, so that it starts to change the way we think about our health, the way we, as a consumer of healthcare, as individuals interested in our health, get information about our health, act upon it, are able to get a better understanding of how our bodies are functioning at any moment in time. Of course, we have lots of wearables today that bring in lots of data, but how is that data being assimilated and tracked and being presented in a way and interpreted in a way that can enable us to meaningfully intervene in our health through getting more exercise, through modifying our diet in real time? I mean, all these are areas that are ripe for transformation as AI becomes better and becomes more broadly deployed. The second part of your question was, are there areas where, we're disappointed in AI? And I think, Mihaela, I think as a general rule, we, as humans, we tend to overestimate what we can accomplish in a short period of time and underestimate what we can accomplish in a long period of time. So has AI, in its relatively brief history, I mean, large language models, right, just came to the broader public in November of 23, right? So a little over 2 years ago. Has it completely revolutionized the way we deliver healthcare, the way we do biomedical research? Well, of course not. But it's already had profound impact. And for all of us who've used large language models, whatever iteration you choose that's out there, I think we've all been profoundly impressed at the way they're able to assimilate knowledge most of the time, but also concerned that we still do see hallucinations. And particularly when we're talking about someone's health, or we're talking about important steps in biomedical research, we have to have our eyes wide open about when hallucinations may occur. We also know those are going to get less and less as the models become more and more trained and roll out more broadly. But right now, it's important to have our eyes wide open about those possibilities, about the realities of hallucinations, or with regard to ambient AI, when it simply gets something wrong, when the way it brings together what the patient and the physician is saying simply doesn't represent what was actually done. That's not as common as it was when we first started deploying it, but it still occurs. So I would say, are we disappointed? No, because I hope we went in with realistic expectations and also with realistic guardrails. And I would also, Mihaela, as I've thought about AI in healthcare and biomedicine, we talked about the areas where I think it's going to have profound impact. I would also identify 3 broad areas of concern, which I think everyone's aware of, but they probably merit stating. The first is that we have to protect privacy. And large language models, as they begin to incorporate social media data, even innocent queries that don't reveal protected information, even innocent queries can lead to the identification of a person because these models are able to bring in information from so many different sources. So, for example, we and other systems are looking at how we in-license models and use those models with our data and within our ecosystem, but do not release information that pertains to our data outside of our ecosystem. So protecting privacy is a big concern and something that needs to be front and center. Second, we talked about it before, is the accuracy of the models. They're not perfect. They do hallucinate. We need to be aware of that. And we probably should talk during our time this morning or this afternoon about medical education, because it raises the real question: if we have a next generation of physicians who haven't perhaps deeply studied the mechanisms of physiology, of pathology, as much as we have in the past, recognizing that a lot of that's been memorization based, which we want to move forward with, which we want to move away from memorization. But if we have future physicians who are solely dependent upon getting knowledge from large language models, how are they going to know when to ask the question, is this really accurate? Or how are they going to know how to innovate based upon information they're receiving? So, hallucinations and how much we depend upon large language models is another area where we need to have our eyes wide open and have some concern. And then the third area, and it's been covered a lot, and you've spoken and written a lot about this, Mihaela, very thoughtfully, and that is, how do we make sure that large language models don't perseverate and increase bias? We know that large language models are only as good as the data on which they are trained. And unfortunately, a lot of that data in healthcare has not been obtained through broadly representative populations. We're getting better at that with having clinical trials that have enrollment that's more diverse, more representative than clinical trials were in the past. But still, we have a legacy issue here of a lot of data that didn't represent that broad emphasis on representation. So we have to be aware, and when we are aware of the possibilities of bias, there are things we can do to correct for that. And we've had our faculty here who, for example, looked at algorithms that look at the characteristics of chest pain to be able to predict, based upon the presenting signs and symptoms, the probability that a person is having a cardiac event versus, a non-cardiac event that wasn't as acutely emergent. And we can correct for the biases that occur when those models are trained on non-representative data sets. But we first have to have our eyes open about the existence of the biases.
Thank you so much. So quite optimistic and positive view about AI in healthcare. And I'm not surprised Stanford being so much at the forefront of both AI and healthcare. Quite a few times in what you said, Lloyd, it reminds me of our discussion 5 years ago when we both got very enthusiastic about rethinking, and I remember rethinking together in that conversation, the future of electronic health records. So like you rightly said, we depend on data. This data largely comes right now and it's stored in electronic health records. We know that everything is polluted to some extent by the fact that the data is not only about healthcare, but is also in many countries about insurance. But it is not only just about insurance. Electronic health records, through their inherent nature, are at times not very easy to store in a good way, in a comprehensive way. Not only the biomarkers of a person, but also what's not measurable, but which amazing clinicians always know. When they see the patient, they observe all sorts of factors about that particular patient. And some of those may make their way into notes, but since now the conversation is recorded or is, let's say, summarized by AI, the challenge becomes that the clinician will need to go back and edit to those notes something that was not spoken, but the clinician has thought about. So that's a challenge. Right. And more generally, electronic health records are, of course, on one hand wonderful because we are digital and we are not having pieces of paper anymore, at least in many countries. This is changing. At the same time, the data is stored in not necessarily the most friendly way. And if you start to think about longitudinal let's say, trajectories of patients that may have comorbidities, as you say, that brings another challenge, because ideally, as we were discussing back then, you want to turn these tools not only in a data extraction and data entry, but also as visualization tools, as analytic tools, and integrate these AI tools to really help the clinician have these maps of where the patient has been and where he's going to. How did your thoughts changed in the past 5 years since we didn't talk about it? And I very much look forward to hear your thoughts, and maybe in another conversation I can update you on mine. But I'm very excited to hear your thinking.
Well, thank you. And I want to congratulate you, Mihaela, because I think you have thought for many years very, very seriously and thoughtfully about how electronic health records can become more than electronic filing cabinets, and how we can really unlock the potential of the information embedded within vast quantities of data. You mentioned before the example of the physician who has an encounter with a patient. At the end of it, and ambient AI is being used, and at the end of it, they have to add a lot because there's a lot that's going on in their head that they simply didn't verbalize during the meeting. What we're discovering is that for both our clinicians and for the AI, it's a two-way learning process. So the clinicians, the physicians are learning, I need to say something, in order for the ambient AI to pick up what my thinking is. So, for example, a patient that's coming in to be evaluated for chest pain, the physician needs to say, I see that you had a stress echocardiogram done a year ago and it was completely normal. This chest pain seemed to occur after you ate a very spicy meal. I'm thinking that it's probably more gastrointestinal than it is cardiac. I mean, that inference, you can maybe one day that inference would be made by generative AI looking back, knowing that the patient did have a stress echocardiogram a year ago and it was completely normal. But right now, it's not going to transcribe what's not said, and then that does change a little bit the way clinicians communicate during an encounter. One can make the argument that that may be a good thing because they're verbalizing to the patient what's going on in forming their clinical assessment of what the patient is experiencing. But there certainly is a two-way learning curve here, both with the AI, but also for physicians learning how to responsibly deploy the AI.
Jump and ask you about an area that I'm very interested in now, but as a builder, not as a user. And I want to hear your thoughts as a visionary user. It's increasingly interesting to think about building these co-pilots to some extent, building for the clinician, of course, also for the patient potentially, but let's focus on the clinician. And of course, there are two types of clinicians, like you, the clinician seeing patients and the clinician doing research. So I'm talking now about both clinician types, the clinician seeing a patient, having a patient in front of them, how can they engage with co-pilots, AI-enabled co-pilots, and conversely, how can a clinician researcher engage with these co-pilots? So I'm curious if it would be to have a wish list, let's say, for people like me and for our community. What should these two types of co-pilots have? What they should enable you to do? And how do you see the future, if you like, of these co-pilots building through time?
Exactly. I think it's a very exciting future. So first, on the clinical care delivery side, for example, co-pilots that we're using right now are involved in activities such as providing a synopsis of a very complex medical record, so that in the example I mentioned before, the emergency department physician seeing a patient at 3 a.m. Who has 12 medical comorbidities, is on 8 medications, and comes in with a new complaint, using the co-pilot to extract information from the medical record on what is most pertinent to the complaint and the physical findings at the time the patient's being seen in the emergency department, That's proving to be a tremendous benefit. Our emergency physicians are really utilizing it, and of course, it's being trained in real time. What's exciting to me about co-pilots is that they should enable each physician to work with, in the way the name suggests, to design the co-pilot that helps them in their practice, in their way of practice, deliver the very best care to their patients. In other words, a one-size-fits-all co-pilot in clinical care delivery is probably not desirable. So for specialists in a particular area that are seeing patients related to the complaint and the problem in their area of specialty, then training co-pilots that go in and extract information both from the history and from the medical record that are most germane to that specialist delivering the care in their field of expertise. It is a desirable feature for a co-pilot. In other cases, the co-pilots may need to have a different function. But all of this is, as you well know, because you work on these systems, Mihaela, all this is very feasible given the technology we have today. It's just a matter of rolling it out, training physicians, and training the models in a way that can be personalized for the care and the practice patterns of the physician and their patients. On the biomedical discovery side, there I think we're in a real renaissance. Of course, the people who developed AlphaFold won the Nobel Prize in Chemistry this year or last year. What a wonderful and well-deserved recognition. Now those technologies, those large language model approaches are being applied to nucleic acids, to studies of the interactions between proteins and their receptors. I mean, this has opened an entirely new field of discovery.
Sorry
And
to
we
jump
see a
in.
lot of
Sorry to
company
jump
formation.
in, Lloyd. What about physiology and more clinical medicine? So let's the
Yeah,
discovery side. Do you think that
right.
such co-pilots could empower clinical researchers like you to think differently about the foundations of medicine and physiology?
Absolutely. And that gets into this important topic of medical education. You know, we've been gradually moving away from a memorization-based approach to medical education, but still probably the best analogy for medical education, best corresponding analogy for medical education would be learning a foreign language. To learn a foreign language, you have to know the vocabulary, you have to know the grammar, and then you have to learn how to communicate in the vocabulary using the grammar. Um, that may change, just as, by the way, we have translators today available electronically, including one I think that's being used during our conversation today. That may change the way we need to educate the next generation of physicians. But I think we're all a bit wary of moving too quickly into that because, as you just stated, I think we still need to have a basic understanding of physiological processes. But how can then large language models help us understand and process that information in a more logically connected way, for example, than perhaps we'd learned it in the past, where we just study individual organ systems or individual mechanisms, and then somehow we're responsible, in our own minds of synthesizing everything together. Seems to me that large language models can help us in that final step in the process.
I have a final question before I let the two teams and our audience to ask questions. And I'm already monopolizing you for too long, but I'm so excited about this conversation. I want to ask you if it is to look 5 years ahead, 3 to 5 years ahead, and then maybe 10 years ahead. If you could achieve one transformative change using AI in healthcare at Stanford, what would it be and why?
Yeah, it's a great question. It's almost like a parent who has, 5 or 6 children and choosing who's your favorite child. Most parents don't want to do that. Um, I think, what is most exciting to me is developing the core resources with regard to the development and deployment of large language models so that we have a core resource group that will enable a researcher, a clinical trialist, a physician in practice with a busy practice to come to this repository of techniques and knowledge and methodologies and say, I would like to do this better, help me transform my processes, my work by the responsible deployment of large language models. It's analogous to what we have today. We have core resource centers in areas of cell biology like fluorescence activating cell sorting. That technique is used broadly in multiple areas of biomedical research. We have the core facilities to where you don't have to reinvent that in your laboratory. You can come to one of our core centers where there are people who are doing it every day of the week, who have a lot of expertise, who can help you design the experiments and the systems you need. I hope we have the same sort of resources available across the board for anyone involved in our enterprise who wants to think creatively about the deployment of large language models in their particular work and professional environment. So that's what excites me the most.
Thank you so very much. It was wonderful. I wish I could keep on going and pick your brain, but I'm going to try to refrain. Tim Schubert and Tim Osterling, now the floor is yours for your questions. And of course, I invite the audience to take this fantastic opportunity to ask Lloyd questions.
Brilliant. Thank you both. This has already been a very insightful discussion. So you already talked about medical education, and this is definitely an issue that's quite dear to our heart because Tim and I are still medical students, and we've just recently written a piece about AI education for clinicians. And in that, we sort of try to define levels of medical AI expertise that future clinicians could have. And we sort of have this three-tier framework where you start with potentially just basic skills. That's just being able to use the tool. Proficient skills, which would also include knowing about ethical implications, knowing about the backgrounds of machine learning, and then sort of the highest tier, which would be expert skills, which means you really understand what's going on and can actually develop your own tools. Where do you think medical education should put the average clinician once they're done with medical school?
I think all three are necessary, and I'm glad you described those. You described the three aspects or the three areas so eloquently. For an institution like Stanford, we want to be training people in all three, but in particular, we want to be a leader in training people in that third group that you mentioned, and that is people who really do have the deep domain expertise in not only the deployment of large language models, but in their development and in their in their evolution. And that requires a person who is going to have a foot in both camps, more than a foot, who's going to be established both as a computer scientist, as an expert in AI, and someone who really understands biomedicine and healthcare delivery. And we want to be a place that offers training opportunities for those people. And so looking at how we have MD, PhD programs in biomedical informatics, for example, even people who have a PhD in computer science and who are trained as a physician. Those are opportunities we want to provide. I think more broadly, we collectively want to be educating our current physician workforce in the United States, around the world, in the deployment of AI and its responsible deployment, in its opportunities and its challenges. And we do that through our medical education curriculum, but also very much through symposia and activities that we host. So we started an initiative in the summer of 2023, we being myself and Fei-Fei Li, the co-director of the Human-Centered AI Institute at Stanford, realizing that large language models were going to have so much potential for transforming everything in health and healthcare. We started an initiative we call Raise Health, Responsible AI for Safe and Equitable Health. We had an international conference this past May. We'll have another conference coming up this spring or summer but really to convene people to discuss what's going on today, what the opportunities are in the future, and to get the feedback on the responsible deployment of AI. But the pace of discovery and innovation in AI in large language models as they're applied for artificial intelligence has been more rapid than anything I've seen in my career. Just looking at the first generation of ChatGPT, for example, in November of 2023, and the large language models we're using today, that's a little over 2 years, but they're radically different in terms of their power, the information they furnish, and their ability to really give us insights. Um, and that, and I think, although a lot has been written about, we can't expect necessarily that pace to be at the same exponential increase, but we'll continue to see evolution in the technology. We need to make sure that we're transmitting that information to others and engaging others in discussing about the responsible deployment of the AI.
Thank you. Yeah, that makes sense. And I think it's interesting that you say that you really want to foster this expert kind of person. I think that makes a lot of sense, especially if you want to be innovative in that area. And I think because you just mentioned LLMs, there's actually an audience question on that. I'm not sure if it's more directed to you or Mihaela, but Tim, please.
Yeah, there was an audience question about that. But maybe first, in interest of time and keeping it all as well as possible, I would like the first question of us that we prepared as well to be how the role of a typical clinician will change in the future. If you look ahead, how do you think their clinical practice will be changed? How will they interact with the tool? How do you foresee this?
I'm an optimist by nature. I think I'm overall very positive about how the role of the clinician will change, will improve. And Mihaela has written a lot about this. The initial introduction of electronic health records had some unintended consequences. One we've already talked about, and that is it dramatically increased the documentation burden for clinicians. And that documentation burden separated clinicians from their patients inadvertently, but it did, because clinicians were faced with the trade-off between not doing any documentation during a busy clinic session and then being faced with 2, 3, 4 hours after the clinic later that day and doing the documentation, and also with the very real possibility that they'll get things confused over the course of seeing 20 or plus patients during that period of time. Now, with generative AI, with ambient AI, with the revolutionary changes in how we do documentation, we should be able to get back over time to a setting in which an encounter between a clinician and a physician really is a deep connection between the two of them, and restore that personal aspect of health and healthcare that was really challenged with the initial introduction of electronic health records. So I think that's one area that we can all be very excited about. Also, in reducing medical errors, I think we're seeing some early evidence that can occur, but we're still in the early stages of the deployment of generative AI in the delivery of healthcare. And so I don't think we're seeing the type of whole-scale, large-scale transformation that I believe we sense can and will occur. But it's going to take time, and it's going to take a very careful deployment of these systems in order to get to that point.
Yeah, I completely agree with you. With the documentation part, it's often, do I take notes now and give suboptimal personal interaction, or do I do documentation in the evening and take subpar notes? That's kind of the payoff you're having. I think there's also a very good question in the chat from somebody, from Julia. You can also unmute yourself and ask it live. This is a live session after all, so please do if possible.
All right, great, thanks. So because I put so much time into formulating the question, I would just read it. So given the increasing role of AI in medicine, you talked about merging the expertise of medicine and bioinformatics within one person. So do you think it's really necessary to have this merged into one single individual to achieve an impactful innovation, or are there alternative approaches to fostering effective collaboration in any other ways between these disciplines? And if so, what would you think would they be to ensure a seamless integration of medical experience and technological advancements?
Thank you. It's a great question, Julia. And I think, first of all, does every clinician need to be an expert in how large language models work, in being able to develop and modify at the level of the model itself, a large language model as it's being deployed in the delivery of healthcare? And the answer to that, I think, is no, certainly not. Just as today, most radiologists are not going to be the ones who understand how or are focused on how MRI technology can be changed in order to deliver better images in a shorter period of time. But there are a group of radiologists who very much do think about that. And they tend to be at academic centers at Stanford and other places. So I think defining what is needed in order to be a real expert in not only the deployment and the use of a large language model, but in its development and evolution, and making sure that we have a group, probably a small group, of people who have true expertise in that domain, as well as in the delivery of care. That's going to be important. That's where I think Stanford has an important role, and other institutions as well. And we also need to be, as Tim and Tim mentioned, we need to be thinking about how we educate the next generation of physicians on, so that we have enough understanding about how these models are trained, their limitations, and all their opportunities. That needs to be broadly understood by all practicing physicians. And again, returning to the radiology analogy, it's important that anyone practicing medicine understand what imaging techniques exist in order to identify a pathological condition. You don't necessarily need to understand how those imaging techniques work, but you need to know that if you want information about the heart in this area, an echocardiogram gives you this set of information. A cardiac MRI gives you a complementary set of information, but distinct in some ways. You need to understand then the indications, the limitations, and the applications of the technology that's available. And I think that needs to be the case in the deployment of large language models also.
Brilliant. Thank you. And in the interest of time, with everything that we've already talked about, one big question we really wanted to ask is, how do you think the role of a typical clinician will change in the future? And this is just really looking ahead, maybe for more than 10 years even. What is your vision for the future clinician? How will their work look like?
I think at a high level, future clinicians will be more able to interact with, deeply connect with their patients than perhaps we're able to do today, because a lot of the time we spend as clinicians today in documentation, in the administrative aspects of medicine, a lot of that is going to go into the background and be taken care of by generative AI and comparable technologies. I also think that even independent of AI, we're undergoing a reevaluation of the role of the physician relative to the roles of other healthcare providers. For example, the role of advanced practice providers in the delivery of primary care. In parallel with what we've been talking about in the healthcare delivery system, large language models are going to give us, as consumers of healthcare and as responsible for our own health and well-being, are going to give us access to a lot more information and actionable information than we've had in the past. So everyone's aware of Dr. Google, that is the patient who comes in having searched their symptoms and in many cases actually pinpointed their diagnosis. That's going to be taken to a whole new level with the responsible deployment of large language models. So I'm not exactly sure how all this is going to shake out, but overall, I see a lot of the joy of the practice of medicine being restored because a lot of the burdensome aspects, I don't think any of us went to medical school or trained as biomedical scientists or physician scientists or primary care physicians. I don't think any of us went into it because we loved documentation or we loved the back office functions. Those were necessary evils in order for us to be able to deliver outstanding patient care. If we can reduce those burdens, then we restore a lot of the joy to the practice of medicine.
Yeah, I fully stand behind you with that one. I think also in the interest of time, we maybe do one more audience question. I will ask it to you, Mihaela, because Professor Minor was also talking about the potential biases that these large language model inherently have because of their training. How do we, and that was Adaise who asked, how do we ensure that these language models are both clinically effective and also scalable across different patient populations?
Well, that's a very important question. And what's interesting here is there is already an entire field that focuses on data aspects and the role that data plays in everything we do in the eye. We call this data-centric AI. And our lab, but also many others, including many others in Stanford, have contributed quite a lot to this field. But I think there is a new dimension now with the large language models. And I think that we really need to go back, at least in the research community, in the machine learning research community, to think very carefully about the biases we are bringing to these models. And this is not only about data, the way we often think about it. We think in terms of features or covariates or characteristics of the patient. But what's also tricky, there is also bias in interventions. So let's say if we learn from data sets from a particular hospital, such as Stanford, well, maybe what we learn in Stanford, we can't bring in a particular underdeserved place in Africa. Also, there could be assignment biases due to differences in expertise, differences in insurance, differences in know-how. So I think there is an opportunity, though, to correct biases that humans have as well. So it's on one hand, you need to be very wary and be careful that AI doesn't learn from bad biases, from undesired variation in practice in the data. But on the other hand, there is also an opportunity to learn the correct variation. And it could be that maybe we practice medicine in a way right now, but by looking with the eye at these differences in expertise, we discover that some people have figured out a new way to deal with this that is not known in other areas, in other countries, or in other, let's say, hospitals. So I think that there is an opportunity to both do a lot of harm, and we need to be very careful. And this is where people like us, the AI people supporting this research, need to be very careful. But also we need to be excited about some of the, let's say, differences in expertise and see it as an opportunity to learn from variation in practice, some of which may be very desired and may reduce costs and may reduce inequalities. So I think that that's a very important question for the research community as well of machine learning.
Yes.
Thank you. And I think in the interest of time, Dean Minor, I would just give you the stage again for a final statement. Basically, anything you would like to add that hasn't been said yet.
Well, first, I want to again thank you for inviting me to spend some time with you this morning. And I want to thank everyone who's joined this group. We're in a very exciting period in the history of healthcare. Mihaela, thank you for inviting me to this wonderful event, and thank you for all the work you're doing. And I would just encourage people to keep a positive attitude. We need to keep our eyes wide open about the limitations and the problems. But I do think the good will prevail in the application of AI. It will only prevail, though, if we're engaged like we are today in responsible, informed discussions about how AI should be deployed, how it should be tested, how we should protect against invasions of privacy, how we should detect and correct hallucinations, and how we should use AI to address some of the historical biases in the delivery of healthcare in a way that overcomes those biases by having AI bring them out and bring them to the fore so that we know the steps we need to take to overcome them.
Thanks, Lloyd, for making time after your extremely busy schedule to be with us and inspire us.
Thank you. Have a good day, everyone.
Thank you so much.
Bye.
And goodbye. Thank you. For everyone who's still on, we will just show you what the next sessions are gonna be. I think they'll come up in just a second. Yes. So in February, we're going to talk with you about co-pilots for healthcare. This is going to be more of a broad core concept thinking session type of thing. In March, we're really excited to talk about oncology, probably one of the fields where AI can have the biggest impact. And then in April, we'll go to something that we didn't manage to cover today, but that's really important, the validation of clinical AI tools. And this these sessions, of course, are free to attend, so please do spread the word and tell other people about them. Also, we wanted to mention that maybe some of you have already been, I think I've seen some familiar faces from the summer school this year. The summer school is going to be back in 2025, and information on that will follow. And this session will be up on YouTube soon, as always. So thank you so much for being here today, and hopefully see you next time.